Good morning, everybody. We're so glad that you could join us this morning for our first webinar in this series. We're getting ready for open enrollment. My name is Ray Walker, and I'm the director for the Medicare Assistance Program at the Oklahoma Insurance Department. And we were so glad that we were able to put together this series of webinars with the assistance of the staff of the CMS Dallas Regional Office. These are the experts, the people that work with this stuff every day. So they were kind enough to volunteer to do these presentations for us, and we think that you're going to find them very, very helpful. So I wanted to remind you, since we're talking about the webinars, we do have, there's like 7 of these, and we've got the one next week is October 13th. Melissa Scarborough is going to be talking about Medicare Part D, the prescription drug plans. There's some changes that are taking place there. Last year in Oklahoma, we had 30 different Part D prescription drug plans. This year, we only have 23. So clearly, there's going to be some people that are going to have to be making some decisions about their Part D coverage next year. So it might be a good idea to participate in that one. Then the week after that, on October 20th, Carmen Irwin is going to be talking about Part B, where there's also been some changes, premiums, deductibles, things like that. So would encourage you to attend that. And then Angela Kane, the following Wednesday, will be talking about Medicare Advantage plans. And these are going to go all the way through November 13th. So we hope that you'll take advantage of that and join us to learn more about what's going on with Medicare for the coming year. So without further ado, let's go ahead and get started. I did want to make one more pitch in case I forget to say it at the end. Open enrollment, if you don't know it already, October 15th through December 7th. Folks, it's very, very important that you take advantage of this opportunity to review your drug coverage, to review your health coverage. I find out, do I have the coverage I need to go into the coming year? There's also been some changes if you are someone that's on a Medicare Advantage plan. Some of those plans have shifted as well. We received notice that there's going to be about 1,600 Oklahomans whose Medicare Advantage plan might not be available next year. So probably a good idea for those people to be contacting us to find out what might be available for them for next year as well. We know that other things have probably changed about your coverage. Maybe your doctor is giving you some new medication. So don't assume the coverage you had last year is going to be the best coverage for you for the coming year. So let's go ahead and get started. I want to introduce our speaker for this morning's session, Gaye Humphrey. I don't even know how long Gaye's been with the Centers for Medicare and Medicaid Services, but she's certainly been there longer than I've been here. And she has been kind of my mentor for all of this time. She's one of the first people that I met at CMS, and has been a wonderful resource for the Oklahoma program in terms of getting us answers to the questions that we have, working with seniors, coming and doing presentations. She's wonderful to work with, and I think that you're going to find her very, very helpful in answering your questions as well. So we're going to listen to Gaye's presentation, and then once Gaye is done, we will have a chance for you to chat in your questions. The chat box is down here in the lower right corner. You can just type your questions in there, and we'll be keeping track of those. And at the end, we will post those questions, pose those questions to Gaye before the end of the session. So I am going to shut up now. And Gaye, are you with us? Turn on your camera and unmute yourself.
I'm with us. My voice may not be, but I am.
Oh, good. Well, you're. Yeah. I'm going to pass you the ball so you can share your slides.
Fortunately, I have water, so we're good. But good morning, everybody. Thank you so much for being here today. And I hope that you learned something and that we have some fun along the way. So, all right, let me see if I can share my screen. Give me just 1 second and I'll have this set up for you.
Looks good.
All right. Wonderful. Well, as I said, thank you so much for being here. And today what we're going to do, I'm trying to get this little picture over here. Today what we're going to do is just talk about what are some changes? What are some different things that we're going to be seeing with Medicare? Some of these are behind the scenes, and you in your day-to-day life will not really notice that some things have changed. There'll be some other things that'll affect you directly, and so we just want to make sure that everybody has the most current information and the most accurate information about the Medicare program. So let's just move forward and
Hey, Gaye.
yeah.
I'm so sorry to interrupt you, but I did need to interject because I failed to do this before we got started. I am responsible for letting everybody know who is attending. We are recording this session for those individuals who signed up but weren't able to attend. So all attendees, just wanted you to know we are recording the session. So if we do need to send that to someone, just let us know. Sorry, Gaye, go ahead.
Not a problem. Thanks, Ray. All right. Here's just our table of contents. We're going to talk about several different aspects of the Medicare program and some changes. Also, you know, our agency's name is the Centers for Medicare and Medicaid Services. So we do have a couple of updates to Medicaid as well as a couple of updates for our health insurance marketplace. So basically what we're hoping is that you'll have an understanding of these changes that are happening. And you, if you need to, you could explain those and also, you know, understand what's happening with the health insurance marketplace as well. So our first lesson is going to be just talking about original Medicare updates. You know, original Medicare is just what it says it is. That's Medicare Parts A and B. That's how it started out before we, years later, were able to add more programs that offered more and better benefits for Medicare beneficiaries. Every year we show this slide as we're moving into our presentations, and this is a map showing where the Medicare beneficiaries are and the numbers that there are across the states. And you see that Oklahoma has somewhere between 300,000 and 600,000 Medicare beneficiaries in the state. And that big orangey red place, I am so sorry, excuse me just for a moment. Okay, I think I'm better, maybe. You know, when you're home by yourself, you don't talk to yourself too much. I wasn't aware I was quite so croaky. But what we're seeing here on this map and with our statistics is, as of last year, we had about 63 million people who were Medicare beneficiaries. 2021, we're looking at about 67 million people. You know that there are 10,000 Medicare beneficiaries turning 65 and aging into the system every day. All those baby boomers are finally growing up. And by 2031, it's projected that we're going to have approximately 71 million folks on Medicare rolls. So the first thing we want to talk about are some changes that came through the Consolidated Appropriations Act of 2021. So these are things that were acted on this year. We're going to talk just a minute about enrollment simplification, a waive of Medicare coinsurance for some colorectal cancer screenings, expanded access to mental health services, and coverage of immunosuppressant drugs for folks who have end-stage renal disease and have a kidney transplant and are Medicare beneficiaries. So let's talk first about the beneficiary enrollment simplification. Probably most of you are already enrolled in Medicare, but beginning in January 23, there is going to be a change in the enrollment process, and it's kind of it's an important change, but it's one that if a person isn't enrolled in Medicare already, they may not even understand the implications of it. But when a person turns 65, we have a 7-month window. That's 3 months before the 65th birthday, their 65th birthday month, and then 3 months following. And of course, the sooner you enroll, the sooner your coverage begins with Medicare. And so beginning in January 1 of 2023, the people who decided to wait until the last 3 months of their initial enrollment period, those 3 months following their 65th birthday, or people who enroll in the general enrollment period, which is an enrollment period from January 1st through March 31st for people who missed their initial enrollment period. I always say they were having such fun turning 65, they just forgot. And so they missed that initial enrollment period. So people who are doing that now, that last 3 months of the initial enrollment period or during the general enrollment period, the coverage is going to begin the very next month. As it stands now, and will stand through 2022, if a person signs up for original Medicare Part A or B, either the month or second or third month after their birthday, their coverage will be delayed right now for a couple of months before it goes into effect. If you enroll before your 65th birthday or the month of your birthday, then your coverage will begin the first of the following month. But there is a lapse. Beginning in 2023, that lapse goes away, and so the coverage then would begin the first of the following month. Now then, it's even a bigger situation for people who enroll in the general enrollment period. That general enrollment period, January 1st through March 31st, when a person enrolls this year and also in 2022, if they enroll in Medicare Part A or B, their coverage does not begin until July 1st. And so there are a few months that even when they've registered and enrolled already with Medicare, they're not getting their coverage. So that goes away in 2023. Their coverage also will begin the first of the following month when they enroll. So this makes a little bit of a change in the enrollment penalties amounts that people would have to pay. Also, special enrollment periods can be established for individuals. The person who does that, who approves those, that authority lies with the Secretary for Health and Human Services. So we would certainly hear about those. And special enrollment periods are just what they say. They're periods that come along occasionally and give people an opportunity to enroll outside of the general structure. All right, the next topic we're going to talk about is waiving the Medicare coinsurance for certain colorectal cancer screenings. And these are the cancer screenings that remove a polyp or other tissue. So, a person would go in for their colonoscopy, and if a polyp or other tissue is found that needs to come out, most of the time the doctor doing the screening just goes ahead and removes that. Beginning in 2022 and then going forward until 2030, the copay that you're going to pay for those procedures, if you have to have one of those, is going to go down, and it's going down incrementally. It'll stay at the same 80%. Medicare Part B pays 80% of the cost of your treatment. The beneficiary is responsible for 20%. So it will stay the same in 2022. You see, in 2023 to 26, your copayment would just be 15%. 27 through 29, it would just be 10%. And then beginning in 2030, Medicare will pay 100% of that cost. So your costs are going down. The reason for this, well, of course, it's been something that's been debated in Congress and all of those things. But what we know is that we want to make it where there are no barriers for people to get the preventive tests that they need in screenings. And so having to pay even that, 10% or 20% copayment could be a barrier for some people, and just what they needed to keep them from going in and getting the tests that they need. So this will just be another way that we're removing barriers so that people will go ahead and get their preventive screenings. Right, another area that has really exploded during the pandemic has been telehealth. And maybe you have even had a telehealth visit with your physician or other providers. You're able to have a conversation with them and a consultation, and perhaps sometimes even, some screenings can happen over the telephone. And so really important area of our healthcare is our mental health care. And the telehealth has really been a wonderful, wonderful boon for people who cannot get out and go to an office and see a physician or counselor. And telehealth then came into play. At the end of the public health emergency, which we don't know when that is, but there will be a proclamation, we declare this public health emergency to be over as of whatever day it is. The very next day, these telehealth services will continue to be in effect for mental health visits. This is huge because people will not have to worry about having a lapse in coverage or a lapse in the opportunity to speak with their physician from their home rather than going to even another clinic or hospital area and having a telehealth visit. They can do this from home. Right. Another big change that's happening with folks beginning in January 1st of 2023 is the fact that people who are on Medicare because they had a kidney transplant, people with end-stage renal disease is the disease that we talk about, that puts a person in a position where they need a kidney transplant. Once they've had that transplant, currently Medicare pays for 36 months. The person is still a Medicare beneficiary, and they get the Part B coverage solely to pay for the immunosuppressant medication that they need. So we see here that past the 36 months now, Medicare will be able to go ahead and be enrolled in Medicare Part B in order to get those immunosuppressant drugs past the 36 months if that's something that they need. Their premium for Part B will be reduced by 10%. And part of the reason for that is the only reason they're getting this coverage is to cover their Part B until they, of course, age into Medicare, and become a Medicare beneficiary. Then they would get all of the benefits from Part B if they choose to do so. But for these, the premium, as I said, would be reduced by 10%. It would cover their medications for them. And it's also for people who don't have any other kind of insurance coverage. So it's just another way that Medicare is expanding the way that they care for folks. Again, no earlier than January 1st of 2023. But a person who's had a kidney transplant can continue to be in Medicare Part B past the 36 months. Another aspect that we talk about every year when we're talking about new things that are coming along are therapy caps. And we know that the Bipartisan Budget Act in 2018 repealed therapy caps. And this was something that was really significant because folks who were getting speech language pathology help, or they were getting physical therapy or occupational therapy, at that time, up until the Budget Act of 2018 was passed, they had a cap as to how much Medicare would pay. And once Medicare reached that cap that they had paid for the individual, then the person was responsible for those Medicare paid costs past that point. So the way that this happens is now we still have therapy caps, but it does not, the therapy cap does not indicate when the person starts having to pay for coverage that Medicare was covering. What it means is that this is a billing issue. This is one of those things that you won't even probably see. But when the provider bills Medicare for the therapy, after a certain limit, and we see the limits here are $2,110 for physical therapy and speech language pathology combined, or $2,110 for occupational therapy, that the therapy can continue. Medicare will continue to pay, but there has to be a special modifier on the billing that goes to Medicare, so Medicare is aware of this. And then there's a targeted medical review when the threshold amount is over $3,000. However, this is just a random sample So not everybody's will be reviewed, but we want to make sure that Medicare is paying for services that are utilized and not paying for services that are not authorized. So that's the reason for that. Now then, Medicare coverage for COVID-19 related services. If you're a Medicare beneficiary and you've gotten your COVID vaccination, you know that Medicare pays for all of that. Medicare pays for the lab tests and any related services, serology tests, the antibody treatments, COVID-19 vaccines. Now we're looking at the boosters, and Medicare will continue to pay for the boosters for COVID-19 as well. And of course, Medicare pays for all medically necessary hospitalization. Again, it's the barriers that we're trying to do away with so that it's equitable for everyone to get treatment or preventive services for COVID-19. So this will just, as we know, this is going to be continuing as we're still under the public health emergency. Hospital price transparency. You may have heard quite a bit about this, or you may have not heard too much at all. But beginning the first of this year, each hospital is required to publicly publish their rates for certain surgical procedures and for their services. It has to be readable, of course, and accessible by the public. And the reason for this is people can shop and compare, because we know that different hospitals are going to charge different amounts for the services that they provide. So if a person is needing some surgery, they can go and shop and look at these comparisons of hospital services and find the place where they can estimate their cost of care before going to the hospital. So CMS is auditing this, their compliance, and they're also investigating complaints about this that's submitted to CMS. And there are monetary penalties for hospitals who are not participating in this at this time. But there is a proposed rule that just came out in July 19th, proposing to increase the amount of the civil monetary penalty that the hospital may face in 2022 for non-compliance. So whatever hospitals are being charged now as a penalty for not participating in 2022, it's been suggested and put forth, for approval, that amount would be increased. So we'll wait to see if that's finalized. I'm sure we will hear about that. But this is just another way that CMS is working with hospitals and other providers to make sure that they're compliant with the rules that go into place. Let's see what happened. All right. Another change, and these are all, remember, with our original Medicare Part A and B. Beginning in January of this year, Medicare instituted the competitive bid program. Again, we've had this before for other durable medical equipment, prosthetics, orthotics, and supplies. But this year, another one, and it's for off-the-shelf back and knee braces. And basically the way this works is this: with competitive bid, different suppliers bid for what they would charge Medicare for particular supplies. And in this case, it's the off-the-shelf back and knee braces. So suppliers bid for that, and then Medicare determines who the winning suppliers are. And for Medicare to pay for these off-the-shelf back and knee braces, they have to be purchased and billed by one of the competitive bidding suppliers. And so all across the United States, we have 127 bidding areas. In Oklahoma, it's Oklahoma, and it's the metropolitan statistical area. So it does include counties around Oklahoma County and also Tulsa County and around Tulsa County. And so in order for Medicare to pay for these off-the-shelf braces, then they have to be purchased through one of these suppliers. So that way, Medicare pays less the individual pays less. And, it's just the people who competed for the bids then are the ones who won those contracts. Now, if it's a custom one that has to be fitted exactly to the person, they are not, there's no qualification that they have to be purchased from a contract supplier. It's just those that we can just get off the shelf that would have to come from a contract supplier. So that was the end of the updates for original Medicare. Let's look now and see what are the changes that have come to Medicare Advantage updates. You'll remember if you attended any kind of updates, current topics last year, we had a lot of talk about the additional benefits that our Medicare Advantage plans can offer for the folks who sign up with them. And they're usually for people who have continuing chronic illnesses, but there were a lot of different ones. One that sticks in my mind is the opportunity that people have to join a plan which may offer services for them. Say you're a person who has lung issues, breathing difficulties, and if there are plans that could offer a benefit where they would come in and clean the drapes and the carpet and those type of things. Now that's not a curative measure, but what it is, it's a lifestyle measure that will help folks not have as many problems breathing in their own home. And so that was all for last year. Those things were rolling out, and we know that we've seen all kinds of different benefits that have been covered by Medicare Advantage. So let's look and see what's going to be happening coming down the pike this year. Well, Medicare has had special enrollment periods for quite a while, and there are special enrollment periods for exceptional circumstances. There's a special enrollment period to coordinate with group health plans if a person loses their group health insurance and they need to go ahead and sign up for Medicare, and it's not their initial enrollment period. Maybe they delayed signing up for Medicare Part B because they had coverage through their group health plan, and that goes away. So that's a special election period that's already in place. Any person who may have experienced a special enrollment period because the plan they had, Medicare Advantage plan, was sanctioned by Medicare for some reason, for not following the guidelines that are set for that plan. Or there are special enrollment periods if there's a government entity declared disaster or emergency, other emergency. And we've seen several of those this year. And so there is the leeway for special enrollment periods to coincide with that as well. So beginning in 2021, so this year these started, there were two new ones, two special enrollment periods that were adopted. And they both have to do with plans that are having trouble, all right? So individuals enrolled in a plan that's been identified by CMS as a poor performer, consistent poor performer. How do we know that? Listed in the plan finder and also in the Medicare New Handbook, there will be a little symbol by a plan that will deter, I can't even talk, that will indicate that this plan is a poor performing plan. And so, you would have the opportunity then, if you had enrolled in that plan and were not aware that it had been a poor performer, then you would have a special enrollment period for that particular instance so that you could choose a different plan. And the same thing goes for plans that are placed in receivership. They financially are having problems, and that would be indicated, and a special enrollment period would be announced for that. And the people who have that plan would also get the information and have the opportunity to change to a different carrier for their health insurance. Right. So those were the Medicare Advantage updates. Now let's see what are going to be some changes for our Medicare prescription drug Part D update. So let's see what's different this year. All right. Every year we have a change to what we call our true or our true out-of-pocket costs. This is an important number because what it is the amount of money that you yourself or perhaps someone else has paid on your behalf for your deductible, for your co-payments for your medication. It's not the cost of the premiums, but it's for other expenses that you've paid for your prescription drugs. Once you have paid out of your pocket, this year in 2021, I believe it's about $6,300 total, then that moves you into what we call catastrophic coverage, where your co-payments for your medications then would be about a 5% co-payment. And we know that with many people taking many expensive medications, they get to this point quickly in the year. This is something that comes to you either on your explanation of benefits so that you would see what's been paid and you can see how that the plan is tracking your true out-of-pocket costs. Your pharmacist can also help you with that by pulling it up at the counter there when you ask them to help you check on your true out-of-pocket costs. So you will know, am I going to even get to the point where, my co-payments would drop down to 5%. Now, many people worry that if they change plans, they're going to lose the credit for the money that they have paid through the year. But you see here that the true out-of-pocket expense money that you have paid is going to go with you. If you switch plans, that money follows you. Money follows the person to the new plan. So if during the year you do make a change, the money that you've already spent with another plan would still count towards the new plan as well. Beginning next year, 2022, the specialty tiers threshold is going to have a change. Now, a specialty tier is one of our pricing tiers for our medication. Typically, these are going to be the newest medications, the most recently approved for use, those that still, there's not much competition for the production of them. So the costs of them are pretty high. And so a formulary tier that has, these higher cost medications in them are able to accept that particular tier from the exceptions process. Well, what's the exceptions process? One of the ways that Medicare has built into prescription drug coverage is decisions that are made about the pricing of a medication or other medication changes or a medication that's not even covered by the plan, but a person's asking for that. These appeals can cause plans to, review those. It's a 5-step appeal that even goes all the way up into federal court. And of course, there's a monetary limitation on that. But to get the plan to cover this medication, and if the plan agrees to do that, they will cover that one medication for that person for a year. And so there is that exceptions process. And what we're saying is that beginning in 2022, if a plan has a specialty tier and they've got several of these medications that are listed in this tiering pricing, that particular tier can be accepted from the exceptions process, where a beneficiary could not come to the plan and appeal that, I need to appeal the price of this cost of this medication. I cannot pay this. Well, plans can just take a whole tier of medications and say, no, we're not accepting that appeal reason for this specialty tier. So you see that in 2022, the money involved here would be for the full cost of a 30-day supply for medication, and it's $830 or above. That a medication in a specialty tier would have to have that much of a copayment for folks to realize that it was put into the specialty tier and they could not ask for an exception for the price. There's a real-time beneficiary tool that's going to be starting January 1st of 2023. This is going to be very helpful, I think, for our consumers, because what it does is it gives you real-time information about the formulary and benefit information. So let's say you go to the doctor and he says, or she says, I'm going to put you on a new medication for this particular problem that you're having. Well, at that time, you would be able to look on this real-time application, look at the formulary, number one, to make sure that your plan covers that medication. And number two, what is that going to cost you when you go to get it? And of course, by doing that, then you could do some comparison shopping to see, well, it's this much at the pharmacy where I usually go, but over here, there's a different pharmacy, still the same medication, and the price is different. And so you may be able to find the medication at a different pharmacy for a better price. And what this also does, of course, is eliminate some of the sticker shock when people are standing in the pharmacy window trying to act like you always pay, this exorbitant amount or whatever for a medication. Going into it what the cost is going to be. So this will be a tool. Again, it's 2023 before it goes into effect, but you can see how it could be very helpful for lots of folks. All right. Now then, we know with prescription drug coverage that with Medicare Part D, there are what we call specialty tiers. And we also know that there are what we call preferred pharmacies. Well, now the plans can, and beginning in January 1 of 2022, so you may see this when you're looking at comparing coverage for next year, where plans have determined that they are going to set up what we call a preferred specialty tier. The medication in that tier is still going to be, typically it's going to be higher cost medication, but because it's in that preferred specialty tier, the plan is negotiated with the manufacturer and said, let's drop the price of this because we'll get more people to buy the medication through this preferred specialty tier because it'll be less expensive and the volume of sales would go up. So that's what they're hoping for by having this preferred specialty tier. And so we may see some of that in January 1st of 2022, and then see how many other plans follow suit as we go forward with prescription drug coverage. Well, there are pharmacy performance measures that different pharmacies are rated on. And because CMS is not running these particular performance measures, the information has not always been reported to CMS. But beginning in January of 2022, CMS is going to require that pharmacies provide for them their performance measures, provide that to CMS. Because what that's going to help CMS do is understand how the measures are applied. The entity that's doing this performance measures, how are those measures applied? And CMS then can have a better understanding of these measures. And pharmacies, many of whom have complained that they don't feel like that the evaluations are fair. CMS can look at these, see how the measures are applied, and then CMS can report the performance measures publicly so that it increases transparency. You want to know that the pharmacy or any other vendor that you are giving your business is operating above board, that they are on track with the competition and hopefully ahead of the competition. And so what it does then is give people that transparent information about pharmacies, but it also helps the industry as they're looking at standardizing the efforts for performance measures. CMS can have a hand in helping hopefully to make those more palatable for the pharmacies and again, more transparency for beneficiaries. All right. We're flying through these this morning. That was the end of the updates about Part D. Now let's look at what are a couple of updates for Medicaid and the Children's Health Insurance Program, which we call CHIP. And CHIP is actually Medicaid for children whose parents make too much money for the whole family, for the parents to be on Medicaid. But the children can be insured by Medicaid even if the parents make more money. They don't make enough money to provide all of the medical care and pay for the medical care that the children need, but they make more money than Medicaid allows for them to be Medicaid beneficiaries themselves. All right. So, of course, there's mandatory coverage for Medicaid folks with and CHIP for COVID-19 vaccines and all the expenses that go along with that, even for uninsured who are not part of Medicaid or CHIP. There are provisions where providers have an opportunity to bill federal government for all of these vaccines and testings and if there's hospitalization involved or treatments. Then even if someone has no insurance, the federal government is really helping pay for these. The American Rescue Plan has a 100% federal matching rate. So whatever the expenditures are, the federal government to the state, the federal government will then replace that money. And it's going to stay at 100% until 1 year after the public health emergency has ended. So even though the public health emergency may be declared to have come to an end, we're still going to have protection for people for a full year past that point. And then after that, after the year has ended, states will reevaluate and submit back to CMS. Here's how we want to handle COVID vaccinations and treatment, and CMS will work with states then to see how they can coordinate that coverage as well. Another change that's happening with an opportunity to happen, I know that Oklahoma expanded Medicaid recently. Other states have expanded. Unfortunately, Texas is not one of them. But states have the option now to extend Medicaid coverage for pregnant women and add more days to the end of the 12-month postpartum period, or make it extend to 12 months. Right now, it's been 60 days that the postpartum period has been paid for by Medicaid for pregnant women after they've had their child. But the option now is here for states to extend that to a full year for postpartum care. And then if there is an individual, and we know that sadly this is true, we have babies having babies. So there could be some children who are on CHIP, young girls who are having, who have a baby. And so there will be a separate CHIP program to continue the postpartum care for these new mothers as well, up to 12 months after during the postpartum time. This is going to be limited to a 5-year period, because what we're doing is looking to see, is this a beneficial program? I know that you've seen in the news that maternal deaths are very high in some of our different populations, especially, and many of these populations are Medicaid beneficiaries. And so we want to see if this will be a way that, we can cut back on the deaths of these mothers and the physical difficulties that they have after the birth of the child. So we see here that a continuous eligibility is mandatory for the low-income pregnant women covered in a separate CHIP. And so CHIP will go along with whatever happens with Medicaid. If Medicaid decides to continue this, then CHIP will also be included in that. All right. Health insurance marketplace. We know that the health insurance marketplace just had open enrollment, and we saw huge uptakes in the number of people who signed up for health insurance because they either had unaffordable health insurance or no health insurance. And so This is affordable insurance. It came about during the Obama administration, and we really saw an uptick this year. Now we have that consumers can enroll or change their marketplace plans a couple of times during the open enrollment period or a special enrollment period. Especially for Oklahoma, this is a good thing to know that if the person is an American Indian or Alaska Native, they can change their plans as often as once a month during the year. Of course, we don't encourage people to change plans once a month. You know, the paperwork alone will take a while to catch up with all of that. But if there's a need for that, then they do have that opportunity to do so. The open enrollment for the Medicare marketplace, health insurance marketplace, begins on November 1st, and it's been extended, and it will last through January 15th this year. So it's a longer open enrollment period again, in order to make it easier for people to look at the marketplace plans, those people who don't have affordable or any other health insurance, and see if they can qualify for some health insurance that would be more financially feasible for them. And then at any time during the year, as things change, folks can submit or update their marketplace application if their financial situation changes. Then they can go in and see if they might even receive a little bit more help with paying for their their health insurance through the health insurance marketplace. Surprise billing, surprise, surprise. Have you had this happen to you? This is one thing that came out of the health insurance marketplace legislation. And what happens is, if what we call surprise billing is when a person goes to a hospital for care, and perhaps that hospital's in the network of the hospitals that their insurance, has contracted with. They have their treatment, they go home, and then they receive this surprise bill because one of the physicians in the emergency room or the physicians who treated this person are not hospital employees. They're employees of a group that services the hospital and staffs emergency rooms. And we're seeing this a lot across the country. It even happened to my husband as well, and we were flabbergasted. We had no idea that that's how that worked. But what's happening is these are going to be restricted. This is already restricted for Medicare, for the VA, for Medicaid. Surprise billing is restricted for those. Now this is spreading to instances where a person gets emergency care, and they have a different provider. An employer group coverage, for example, would be the ones, a private group that's not a government group insurance. So there's a centralized complaint desk for consumers, and all of these protections are going to take place January 1 of 2022. So just in a few months, surprise billings will not be accepted and will be restricted as well. There are some plans, some health plans called health reimbursement arrangement plans, and it's just an alternative to traditional insurance. And basically what happens with a plan like this, and these are an employer plan, but employers can provide pre-tax reimbursement to folks to pay for their health expenses, including their premiums. And evidently there's been some problem with some companies not being willing to accept payment through these health reimbursement arrangements. And so now there's a new rule that requires that the plans do have to accept the premiums paid by these health reimbursement arrangements. And we know that when a change like this comes up, there was a problem somewhere, and so it was brought to the attention of those who make these different regulations, and that's what has happened here. All right. Well, this is just helpful websites for you of where you can find things. The Federal Register, if you want to look and see exactly how a particular law or rule has been worded, and where do you find that? So information to get more information, I guess, or where to find what we've talked about today. So this is the end of my presentation. Let's see. Anytime we do a presentation, with Medicare, we put all the acronyms that we used in there in the presentation at the end. So you have a glossary because government ease is full of acronyms. So I'm gonna let my friend Ray help now, and let's see what we need to do about the chat questions. And do you want me to stop my sharing?
It's up to you. If you want to leave the screen up in case you want to go back to one of your slides or something like that, we can do that. The first question had to do with the Part B effective dates during the general enrollment period that you mentioned early on. Someone just wanted some clarification. So we're talking about that January 1st through March 31st time period where historically the effective date would have been way out on July 1.
Yes.
So from what you're saying, it would be, let's say the person enrolls in January during the general enrollment period, their effective date would be February 1?
Yes. Yes.
Okay.
That's what it says. So I believe that's 2023 when that begins, right?
Yeah. I wish it was going to be earlier than that because we're already having some questions popping up.
Two things about that. If your coverage begins the first of the following month, if you're paying Part B premiums, that money starts going into the Medicare Trust Fund that much quicker than waiting till July. So that's one thing. And the other is that it's just an enhancement for people to be able to get their coverage sooner than having to wait so long.
Definitely. Another question that came in, and you're going to love this one. I'm just going to read it straight from the person's wording. I am enrolled in Original Medicare. I have a Medigap G policy and a Part D policy. Why do I get tons of mail wanting me to change policies if Part D is the only thing I can change? Same thing with TV commercials.
All right. Why do I get them? I work for Medicare. I don't want them either. But the reason for that is that you do have an option every year to move from Original Medicare to a Medicare Advantage plan if you wanted to do that. And so that's probably the driver for most of this is the fact that you can go from Original Medicare to a Medicare Advantage plan. And these plans are very aggressive. They want you to sign up. Joe Namath has been on TV till we're sick of seeing him. But we know that they do a lot of marketing. And so there is something you could change if you wanted to. But if you're happy with what you have with Original Medicare, that's super. Certainly it's your choice to do that. And of course, we do encourage you to look at Part D plans in particular. Make sure that the coverage that you have is going to work for you next year, as Ray was talking about before I got started.
Okay, a couple more questions. You were talking about the Part D plans and the change they're going to make performance measures related to pharmacies available.
Yes.
This is information that it wasn't, and there was confusion about this compared to the 5-star ratings that are already available on Plan Finder. And as I understand it, those 5-star ratings actually have to do with the Part D plan, not the pharmacy, correct?
That's right. That's right.
Okay, so the measurements that you are talking about are actually to be able to see how that particular pharmacy that's part of that plan's network is performing.
Yes. Yes.
Okay. Very good. The other question, you had talked about the DemiPose competitive bid program and how it's focusing now on back and knee braces. And the term that you used was off the shelf.
Yes.
And the confusion is surrounding, as you know, if you walk down the aisle at Walgreens, they've got knee braces and wrist braces and all sorts of things hanging on a pegboard. But that's not necessary. That's not these items. These are still items that have to be ordered by a physician.
Yes.
That are covered. The ones that we're talking about with this DemiPose bid are ones that your doctor has sent you for.
Right, yeah. For Medicare to pay for it, it has to have a doctor's prescription for it.
Okay. All right. So there is a distinction between the two there. They may be, they're probably more sturdy, more rigid than those neoprene things that are off of the Walmart shelf there, than what we're talking about. But they're still considered off the shelf because they're not custom fit, correct?
Right, yeah. And you may yourself decide I need a knee brace. I'm just going to go get one of those, and that's fine. I mean, they're right there off the shelf. You can do that. However, Medicare will not pay for it unless you do have a doctor's prescription that goes along with it.
Okay, good deal. I'm looking down my list here to see if I think you pretty much answered everybody else's questions. Thank you so much for joining us. We did get a comment. Someone was wanting to know about where they can get access to these slides, Gaye.
I can send those to you, Ray, and then if you would like to forward them, that is perfect. We are happy for you to do that.
Okay, and also, folks, don't forget, we are recording these sessions. If you just like to get a recording of this, you can always send us an email, and we would be happy to include you on that list to send you a copy of this recording as well. So thank you again, Gaye, for joining us. We're really glad everybody was able to join us today. Don't forget, it is open enrollment period, so take advantage of this opportunity to review your coverage. If you do have any questions, if you'd like more information, give us a call. Our phone number is 1-800-763-2828. That is the Medicare Assistance Program. There's someone that answers that phone 24 hours a day, 7 days a week. We'd really like to help you. Also, don't forget, next week we've got our webinar on Part D prescription drug plans. So if you'd like to learn more about the changes taking place there, please go online to our website, oid.ok.gov, and register for that event. So this concludes our webinar. Hope everybody has a great day.
Ray, how many did we have? How many joined us? Thanks, Paige.
You're welcome. Have a good day.
You too.
Good job.
Bye-bye. Hi. Oh, no, that's okay. I just want to know how many participants we had, and Paige told me we had 42. 53. Let's count them. I know, but people, if we don't charge for it, then. Oh, probably. Yeah. 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 I did too. Yeah, I know. I'm so sorry. My crazy voice. But anyway, it finally got better. But yeah, I have been too. But anyway, I guess I just need to get up and talk to the dog more. I don't know what else. But anyway, I'm sending you the PowerPoint right now. Sure. Yeah. Yeah.